Oximetry. IV fluids. Replacement fluids include crystalloid and colloid solutions. IV fluids improve perfusion but not oxygen carrying capacity of blood. Initial distribution of IV fluids. H2O water follows ions molecules to their respective compartments. Crystalloid infusion. Salt-containing solutions that distribute only within ECF. Consensus guidelines recommend use of balanced crystalloid, i.e. Ringer's lactate, over normal saline for routine replacement and resuscitation. Maintain euvolemia in patient with blood loss. 3 ml crystalloid infusion pair 1 megaliter of blood loss for volume replacement, i.e. 3-1 replacement. Best practice is to use goal-directed therapy if large volumes are to be given. Use balanced fluids such as Ringer's lactate or plasmolite registered sign. As too much ENS may lead to hyperchloremic metabolic acidosis. Colloid infusion includes protein colloids, albumin and gelatin solutions, and non-protein colloids, dextrans and starches, e.g. hydroxyethyl starch, HES, distributes within intravascular volume, 1:1 ratio, infusion blood loss only in terms of replacing intravascular volume. The use of HES solutions is controversial because of recent RCTs and meta-analyses highlighting Thiranol especially in septic patients, and coagulopathic side effects, as well as a lack of specific indications for their use. Colloids are being used based on mechanistic and experimental evidence, but there is a paucity of definitive studies investigating their safety and efficacy. Routine use of colloids should be avoided. Colloids versus crystalloids for fluid resuscitation in critically ill people. Cochrane DB Cyst Rev 2018 CD 000567. Purpose to assess effect of colloids versus crystalloids in critically ill patients on mortality, need for transfusions or renal replacement therapy, and adverse events. Methods: systematic review of RCTs and QA-CRUCs involving trauma, burns, or medical conditions, i.e. sepsis. Searched Central, Medline, and Embase. Outcomes: 69 studies, 30,020 participants. Starches, dextrans, albumin or FFP, moderate certainty evidence, or gelatins, low certainty evidence, versus crystalloids has no difference on mortality. Starches slightly increase the need for blood transfusion, moderate certainty evidence. And albumin or FFP may make little or no difference to the need for renal replacement therapy, low certainty evidence. Evidence for blood transfusions for dextrans, and albumin or FFP, is uncertain. Toronto Notes 2021. Calculating Acceptable Blood Losses, ABL. Blood volume. Term infant 80 ml/kg. Adult male 70 ml/kg. Adult female 60 ml/kg. Calculate estimated blood volume EBV, e.g. In a 70 kg male, approximately 70 ml/kg. EBV equals 70 kg x 70 ml/kg equals 4,900 megaliters. Decide on a transfusion trigger, i.e. the HB level at which you would begin transfusion, e.g. 70 g-liter for a person with HBI, equals 150 g-liter. HbF equals 70 g-liter. Calculate ABL equals HbP, HbHF, XebHI, equals 150 70 x 4,900 150 equals 2,613 megaliters. Therefore, in order to keep the HB level above 70 g-liter, RBCs would have to be given after approximately 2.6 liter of blood has been lost. Transfusion infection risks. Risk pair 1 unit PRBCs. Virus HIV 1 in 21 million. Hepatitis C virus 1 in 13 million. Hepatitis B virus 1 in 7.5 million. HTLV 1 in 1 to 1.3 million. Symptomatic bacterial sepsis. 1 in 40,000 from platelets and 1 in 250,000 from RBC. West Nile virus. No cases since 2003. Source Callum J.L., Pinkerton Ph. Bloody Easy. 4th edition ed.